Now in this video, let us learn a few details about the various cranial nerve nuclei located in the pons. Among the cranial nerve nuclei in the lower pons, we have already studied the spinal nucleus of the trigeminal and the vestibular nuclei along with the medulla oblongata. We will go on to study the cochlear nuclei in the video on auditory pathway, which will be dealt separately. So let us go on to study the remaining cranial nerve nuclei here. Coming to the abducens nucleus, these are located in the paramedian position, in line with the hypoglossal nucleus in the medulla and the oculomotor and trochlear nuclei in the midbrain. All these nuclei belong to somatic efferent column. Oculomotor nerve descends through the reticular formation, medial lemniscus and the basilar part of the pons to exit at the pontomedullary junction just above the pyramids. This nucleus, through its nerve, supplies lateral rectus muscle. That's the only muscle which it supplies, and it's the extraocular muscle which is responsible for bringing about abduction of the eyeball. Abducens nucleus receives inputs from the contralateral cerebral cortex. It also connects with oculomotor, trochlear and vestibular nuclei, as well as upper cervical spinal cord through the contralateral medial longitudinal fasciculus. Now it's important to understand that the right abducens nucleus connects with the left oculomotor nucleus, especially that part of the oculomotor nucleus which supplies the medial rectus muscle, so that when one is looking to the right side, the abduction of the right eye is coordinated with the adduction in the left eye. And of course, this will be vice versa. This nucleus is also connected with the ipsilateral paramedian pontine reticular formation, or PPRF, otherwise known as lateral gaze center. Lesion to this nucleus results in lateral gaze palsy, that is, the eye fails to abduct on the affected side. This can be tested by a simple bedside test. Seat yourself in front of the patient at a distance of about 1 meter. Ask the patient to watch and follow the tip of your index finger. Move the tip of your finger in front of his eyes horizontally, first to one side and then to another. Now, patient's affected eye fails to follow the finger when the finger is moved to the affected side. As seen in this picture here, patient's both eyes following when the finger is moved to the left, but when the finger is moved to the patient's right side, the right eye fails to follow the finger. This is because of the right-sided abducens nerve palsy. Patient may complain about double vision, otherwise known as diplopia, or the patient may complain about a recently developed squint, otherwise known as strabismus, in such cases. Now coming to the facial nucleus. Now these are located deep in the reticular formation in relation to spinal nucleus of trigeminal, that is, they are medial to the spinal nucleus of trigeminal. Neurons of this nucleus migrate forward so as to stay close to the source of their sensory information, which is in this case it's the spinal nucleus of trigeminal, and this process is known as neurobiotaxis. This process is actually observed in all the nuclei belonging to special visceral efferent column. We have already seen this in case of nucleus ambiguus in medulla. The nerve starting from the facial nucleus forms the motor root of the facial nerve. It has a peculiar course where it retraces the path of the migration of neurons in neurobiotaxis. So they wind round the abducens nucleus, resulting in a bulge at the floor of the fourth ventricle known as facial colliculus, and the facial nerve fibers then descend ventrolaterally through the reticular formation and basilar pons to emerge at the pontomedullary junction just above the olives. Now, belonging to the special visceral efferent column, this nucleus supplies all the muscles which develop from second pharyngeal arch, which includes predominantly the muscles of the facial expression. Within the nucleus, the scalp and the upper facial muscles are represented in the dorsal part of the nucleus, and the lower facial muscles are represented ventrally. Nucleus receives inputs from the cortex for voluntary movements, as well as from the solitary nucleus and spinal nucleus of trigeminal, which help in forming the local reflex loops. In case of lesion to the nucleus, it results in paralysis of the muscles of facial expression on the ipsilateral side. This can be again tested by a simple bedside test. Ask the patient to wrinkle his forehead, wink and whistle, typically known as eliciting triple W sign. So failure to wrinkle his forehead or to wink or to whistle should alert the physician to the possibility of facial paralysis. Now, important part is to identify whether the lesion is because of the upper motor neuron lesion or lower motor neuron lesion. So facial nucleus receives corticobulbar or corticonuclear inputs for the voluntary control of the muscles. Neurons in the dorsal part of the nucleus, which supply scalp and upper face muscles, receive inputs from the bilateral cortex. Whereas the ventral part of the nucleus, which supplies only the lower facial muscles, receives inputs from only the contralateral cortex. So the nerve fibers in the facial motor root, which supply the upper facial muscles, are influenced by the cortex on both sides, whereas the nerve fibers which supply the lower facial muscles are influenced by the contralateral cortex alone. Now this is the whole information which forms the basis for differentiating upper motor neuron lesion versus the lower motor neuron lesion of the facial nerve. In case of supranuclear lesion, the contralateral facial muscles on the lower half of the face are paralyzed, but upper half of the face will be spared because they are also receiving inputs from the other cortex. Whereas in case of the lower motor neuron lesion, otherwise known as Bell's palsy, there is a complete ipsilateral paralysis of the facial muscles, which includes both upper and lower half of the face. Now coming to the next nucleus, actually there are two small nuclei which are situated at the pontomedullary junction along the line of the dorsal nucleus of the vagus, one in the upper medulla known as inferior salivatory nucleus, which sends preganglionic parasympathetic fibers through the glossopharyngeal nerve to the parotid glands, and this is the second nucleus which is located in the lower pons known as superior salivatory nucleus. The upper end of this same nucleus is also designated as lacrimatory nucleus. Now these nuclei belong to the general visceral efferent column, and they send preganglionic parasympathetic fibers through the nervous intermedius part of the facial nerve to supply either the submandibular and sublingual glands via the chorda tympani branch or the lacrimal gland via the greater superficial petrosal nerve. Lesion to this nucleus or to the nervus intermedius or to the final preganglionic branches, that is chorda tympani or the greater superficial petrosal nerve, will result in reduced mucous salivation or lacrimation. Now, absence of lacrimation is one of the serious effects of the facial nerve lesion, because paralysis of orbicularis oculi will already result in absence of blinking and complete closure of the eyes, which increase the risk of exposure keratopathy, and lack of lacrimation will result in drying of the eyes, which further increases the chance of keratopathy and corneal ulcers, which may also result in blindness. Now coming to the cranial nerve nuclei, which are located at the upper pons level. The principal sensory nucleus is located in the tegmentum of the upper pons. It is lateral to the motor nucleus of the trigeminal nerve. Belonging to the general somatic afferent column, it receives the ascending fibers of the trigeminal nerve, which carry tactile sensations. This nucleus can be tested by touching the skin supplied by each division of the trigeminal nerve with a wisp of cotton in a patient when the eyes are closed. So touch his forehead, upper cheek and the chin to test whether he can feel the touch or not. Now remaining ascending afferent fibers of the trigeminal nerve relay in the next nucleus, that is mesencephalic nucleus, which is seen in the upper pons, as well as it extends to the whole length of midbrain. Now, as has been noted earlier, this nucleus is triply unique. That is, it is the only nucleus in the central nervous system made up of first order neurons, whereas everywhere else the first order neurons are located in the sensory ganglia. These are the only unipolar neurons in the central nervous system, and belonging to the general somatic afferent column, this nucleus receives proprioceptive information from the head region. Now, fibers of its neurons synapse with the neurons in the motor nucleus of trigeminal nerve, forming the reflex arc for the jaw jerk, which is the only supraspinal monosynaptic reflex. Now, coming to the motor nucleus of trigeminal nerve, it's located in the reticular formation of the upper pons, medial to the principal sensory nucleus of the trigeminal nerve. It belongs to special visceral efferent column and supplies all the muscles which develop from the first pharyngeal arch. It receives inputs from bilateral cortex and also ipsilateral mesencephalic nucleus, which is involved in the jaw jerk. It also receives inputs from red nucleus, tectum, reticular formation, medial longitudinal fasciculus, even from the locus coeruleus. All these connections may mediate coordination between mastication and salivation, because this is the motor nucleus supplying the muscles of mastication. So mastication and salivation will be mediated by its other connections. Now, lesion to this nucleus will result in ipsilateral hemiparesis of the muscles of mastication. How do we test this? We can elicit the jaw jerk. In case of lower motor neuron type of lesion, the jaw jerk will be absent, whereas in case of upper motor neuron lesion, the jaw jerk will be exaggerated or brisk. Now, coming to the nucleus cellulous, this is not the cranial nerve nucleus, but it is located in relation to the upper pons, so let us just know a few things about it. This nucleus cellulous underlies the superior fovea in the upper half of floor of fourth ventricle. Because the neurons of this nucleus have a high content of copper, that gives rise to bluish gray discoloration to the area, which is often visible to the naked eye. This nucleus actually belongs to lateral column of the reticular nuclei. It sends noradrenergic fibers to almost all parts of the central nervous system. That is, descending fibers reach the preganglionic autonomic neurons in the spinal cord. They will also reach the reticular formation and cranial nerve nuclei of the rhombencephalon. They also reach the pontine nuclei. And ascending fibers ascend to the periaqueductal gray in the midbrain, also to the thalamus, deep cerebellar nuclei, and to the entire cerebral cortex. This nucleus probably is involved in controlling attentiveness and sleep-wake cycle. It also helps in maintaining synaptic plasticity. Thank you very much. Hope you enjoyed this video. You can visit this site for the remaining videos on the neuroanatomy.